fatty liver disease. In this session, I'll give you a brief introduction of fatty liver, spectrum of fatty liver disease, clinical significance of fatty liver, and then explain quantitative imaging, quantification of fatty liver disease, and summarize my presentation. Hepatic steatosis is the excessive and abnormal intracellular accumulation of lipid in the liver. It is the most common cause of chronic liver disease in Western countries and recently in the world. Its estimated incidence in developed countries is about 20 to 30%. Fatty liver disease is a dynamic and evolving process, and therefore timely detection and proper management is quite important to prevent from future further damage as well as progression into more advanced stage. What is the clinical significance of fatty liver disease? Fatty liver disease is very common and shows broad disease spectrum by etiology and severity, and is strongly correlated with metabolic disease. Fatty liver disease can evolve into steatohepatitis or cirrhosis, and is an important risk factor for postoperative complication after major liver resection. For example, patients with fatty liver more than 10% are critical for understanding living donor liver transplantation. Now let's move on to quantitative imaging. Current imaging modalities for QI quantitative imaging are ultrasound, CT, and MR, and are the most widely used imaging modality for evaluation of the liver disease. These imaging modalities mainly assess the morphologic change of the liver. However, it has been well known that many pathologic processes often occur before morphologic change, especially in diffuse liver disease. Therefore, we need to evaluate more than morphologic change. Then why do we need quantitative imaging? Quantitative imaging can provide information regarding organ function and can also provide objective measurement, and therefore it can be used in monitoring of treatment response, such as treatment of liver fibrosis or steatosis. And then why do we quantify liver fat? We have to make a diagnosis of fatty liver and monitor the fatty liver disease after treatment. There are several methods for the diagnosis of fatty liver, but every method has problems for the diagnosis. Biopsy is invasive. Serum test is inaccurate. Ultrasound is subjective. CT has a radiation hazard and density error. MR spectroscopy is difficult for precise sampling. Let's focus on to the ultrasound. We all know ultrasound has pros and cons as compared to other imaging modalities. Ultrasound is widely available and there is no need of radiation exposure except contrast-enhanced ultrasound. Contrast agents are generally not needed for performing ultrasound. Therefore, ultrasound can easily be repeated for the same patients during the process of disease. However, operator dependency and subjective nature of examination are main drawback of ultrasound. The subjective nature means it is hard to quantify. Therefore, the question is, can it be possible to do quantitative imaging using ultrasound? My answer is yes. Let's move on to quantification of fatty liver disease. Physical change in progression of hepatic steatosis is increased liver parenchymal echogenicity. So hepatorenal ratio compared to renal parenchymal echo by grayscale imaging could be one of the quantitative methods. More attenuation of ultrasound beam occurs with progression of hepatic steatosis. So attenuation-based quantification could be another method of quantitative hepatic steatosis evaluation. Changes in liver echotexture with increased homogeneity, such as obscuring portal vein and bile ductal wall, is a background of quantitative variance imaging. As I mentioned before, ultrasound quantification methods of liver fat are classified into 3 categories. Grayscale ultrasound, such as hepatorenal ratio, HRR, was previously investigated. Attenuation imaging includes controlled attenuation parameter, CAP, by transient elastography, ultrasound-guided attenuation parameter, UGAP, attenuation imaging, ATI, and ATT. Variance imaging includes acoustic structural quantification, ASQ, and NLV. Among them, NLV is still work in progress. I'll explain those new techniques one by one. I'll start with attenuation imaging, such as CAP, UGAP, and ATI. Ultrasound beam is attenuated when passed throughout the materials. Degree of attenuation is different among the different materials. Fat shows more ultrasound beam attenuation than liver and soft tissue, as you see in this table. Controlled attenuation parameter, CAP, using TE can measure degree of ultrasound attenuation by hepatic fat with unit of decibel per meter, ranging from 100 to 400 dB per meter, as you see in this diagram. CAP is a validated good tool for the prediction of hepatic steatosis, but there are several limitations in CAP, including no morphologic evaluation, small sample volume, impossible incorporation to routine grayscale ultrasound exam, and high technical failure rate. Therefore, beam mode-based quantification of ultrasound beam attenuation is a good potential method to overcome limitation of CAP from TE. So quantitative method of ultrasound attenuation using beam mode imaging has been developed. As you can see in this figure, ultrasound guided attenuation parameter UGAP can calculate attenuation coefficient using ROI in the mid portion of the liver by beam mode. Here you see one recent paper demonstrating good result of quantification of ultrasound attenuation using UGAP. There was strong potential correlation between attenuation coefficient from beam mode ultrasound and degree of hepatic steatosis on histopathologic examination. So attenuation coefficient of UGAP shows a good correlation with grade of hepatic steatosis. ATI is another method of quantification of ultrasound attenuation using beam mode. ATI is an innovative method of Canon company to assess liver attenuation by quantifying attenuation coefficient and to provide clinical benefit for steatosis grading. Here you see one recent study. Our group evaluated the diagnostic performance of attenuation coefficient from B-mode-based attenuation imaging in 108 patients who underwent liver biopsy after B-mode evaluation. ROI was placed on liver parenchyma and attenuation coefficient was immediately appeared on the screen. As you can see in these figures, value of attenuation coefficient increase along with the progression of hepatic steatosis. So attenuation imaging could be a good tool for quantitative assessment of hepatic fibrosis. Moving on to variance imaging. In hepatic steatosis, fat vacuole in hepatocyte reflects ultrasound beam. So fatty liver appears as increased echogenicity or bright liver on ultrasound. Therefore, echo of portal vein or bile ductal wall is obliterated, and increased attenuation of sonic beam induced poor visualization of diaphragm. Those findings make ultrasound imaging more homogeneous, and this phenomenon is a background of variance imaging such as ASQ and NLV. In acoustic structure quantification, ASQ, variance of small ROI is compared to variance of large ROI, as you see in this figure. When the number of small ROIs having variance larger than large ROI increases, it means tissue is more heterogeneous. When there is no small ROI having variance larger than large ROI, it means that the tissue is perfectly homogeneous. And the focal disturbance FD ratio calculated by variance imaging would be 0. FD ratio is positive in case of the presence of tiny structural change. Here are examples of ASQ. In the case of severe fatty liver, grayscale ultrasound shows fine bright echo, which means focal inhomogeneity is very small. Because small reflector signals are attenuated by prominent scattering by fat, as you see in this figure. So FD ratio is low. However, in cirrhotic liver, grayscale ultrasound shows coarse echo, which means high occurrence of focal inhomogeneity caused by small vessels, fibrosis, and so on, as you see in this figure. So FD ratio is high. Our group also published several articles, including this article titled Hepatic Steatosis, Assessment with Acoustic Structure Quantification of Ultrasound Imaging. This is a prospective study with 89 patients having steatosis who underwent ASQ and proton MR spectroscopy. As a result, ASQ cutoff value showed FD ratio less than 0.56 in mild fatty liver and less than 0.1 in substantial fatty liver with sensitivity 86%, specificity 100%, and accuracy 96%. There was no technical failure. In conclusion of this study, ASQ with FD ratio is a good diagnostic tool for assessing hepatic steatosis. And ASQ with FD ratio also affected by stage of fibrosis. Let me summarize my presentation. Hepatic steatosis has become a major healthcare issue worldwide. Ultrasound is an initial imaging modality. Ultrasound quantification of liver fat is important because it is cost-effective, simple, and repeatable. Currently, we have diverse methods for quantification of liver fat. There are three kinds of quantification methods of hepatic steatosis. Hepatorenal ratio by grayscale ultrasound was previously investigated. Attenuation imaging, including controlled attenuation parameter by TE, ultrasound-guided attenuation parameter U-gap using attenuation coefficient, and attenuation imaging ATI and ATT using attenuation coefficient. Variance imaging, including acoustic structure quantification, ASQ, and normalized local variance, NLV. So I think quantification, ultrasound for fatty liver will be promising in the future. Here you see the name of the contributors of my presentation. Thank you.